Hello and welcome to the eInduction module covering how to interpret C-spine X-rays. My name is Thomas Mitchell and I'm a consultant working in the emergency department. This module should take about 10 to 15 minutes to complete. This is the second of 3 C-spine presentations. Before completing this module you should have watched an introduction to C-spine injuries in the emergency department and know when we should be ordering X-rays. During this presentation we aim to cover an approach to interpreting X-rays. We'll look at the different views which make up the standard C-spine series. We'll cover a little anatomy, although you'll be expected to know the basics. If you're not familiar with the bony anatomy of the neck, I suggest reading around the subjects before completing this module to maximise the benefit. Some links can be found alongside this video. We'll then cover how to interpret these views and go over some review areas where we need to concentrate to ensure we don't miss any fractures. The third presentation in the series covers some common fracture patterns and gives you a chance to test yourself. Whenever I approach X-rays, I always like to have a system in the back of my mind. With C-spine images in particular, if you don't have a methodical approach, then you'll miss subtle findings which can have serious consequences. I like to use an AABCS approach. That's adequacy, alignment, bones, cartilage and soft tissues. This can be used to interpret most X-rays. We'll talk through these elements as we discuss interpretation further. There are 3 main views which make up our C-spine series. Each of these can be approached using the AABCS method I've just mentioned. The first is the PEG, or the odontoid view. It's taken at an angle down through the patient's opened mouth. If you have a collar in place, then it's difficult to open your mouth. Often you end up with a suboptimal result. This view is very useful for identifying fractures to the atlas and axis, that's C1 and C2. The second view is the long AP view, that's taken with the patient lying flat in the bed. The lateral view is probably one of the most useful. It's also one of the most difficult to get an adequate view. That's as the shoulders sit up high and obscure C6, 7 and T1. There's one more view which is still routinely performed. If you end up with inadequate lateral views, then the radiographers may try what is called a swimmer's view to capture the bottom few vertebrae of the neck. It's done with one arm up and the other down, rather like front crawl. This gives you an image which, although useful, is often difficult to interpret as there are so many bones overlying one another. This is probably the best view I've ever seen for a swimmer's one. We've not talked about other types of neck X-ray. Other than soft tissue neck X-rays for foreign bodies, we don't routinely do any other views such as flexion extension views. If you think this might be necessary, it's worth talking to a senior. We'll start by concentrating on the PEG view. The PEG, or odontoid view, shows a C1 and C2 and their relationship. This is important as it's a common place to get an unstable fracture. I like to describe X-rays as being like fingerprints. Everyone has individual appearances. This is the same with C-spine X-rays and can cause some concern. If there's anything irregular, then you'll be talking to a senior, so don't worry too much. And this PEG view is a typical place to get some irregular findings. The first thing to do when looking at this X-ray is to work out whether the images are adequate. You must be able to see the lateral masses of C1 and C2 and the whole of the dens, as shown in this image. Ideally, there should be minimal rotation. This can make judging alignment difficult. You can judge the degree of rotation by looking at the position of the incisors and the spinous processes. You may see slight asymmetry in the distance between the dens and the lateral masses also. When we come to alignment, then normally the lateral masses of C1 should align with those of C2, here shown by the yellow line. The distance between the dens and the lateral mass of C2 should be equal on both sides. This is shown by the green line and is sometimes affected by the rotation like we talked about before. This is important as a fractured C1, usually from somebody being hit directly on top of their head or an axial load injury, can cause C1 to burst open and the lateral processes to overhang those of C2. When looking at the bones, you need to carefully scrutinise the dens. Fractures through the dens result in a lucent line to either the top, mid or base of the dens. These can be difficult to see as there are often many associated soft tissue shadows, but are very important to pick up as some of these fractures are very unstable. We'll see later that the dens can also be visualised in the lateral view. There are no cartilage or soft tissue areas to review on these images. An adequate AP image should show the whole length of the neck and catch the top of the lung apices. The AP film enables us to check alignment of the neck. By drawing a line up the spinous processes, which is circled in yellow, we can ensure that they are in alignment. That's the red line. Sometimes you'll have bifid processes, which can throw you. You just need to mark a point between these two bifid processes. If there's a sudden change in alignment, then it may be that you have a facet joint disruption or dislocation, and you've got one joint sitting on top of another. Both the disc spaces and vertebral body heights should be uniform. However, you may find that if the patient's held in flexion, it may not be the case. As a review area, it's important to look at the lateral processes, as these fractures are commonly missed. That's the areas shown in blue. It's also prudent to check for a pneumothorax. It's always embarrassing to miss this in your trauma patient. The lateral C-spine is really where most of the answers lie. Here we have the 7 cervical vertebral bodies labelled. You'll note that C1 has no vertebral body, unlike the others. An adequate lateral spine's view should show you the first half of the vertebral body of T1 and the other 7 cervical vertebral bodies. If you have an X-ray which does not show you T1, then you can still review it. It may have some important clinical findings, but you'll need to formulate a plan of how to image this section, either with X-rays or CT, before you attempt to clear the C-spine. There are 4 very important lines you can draw on the lateral C-spine to assess alignment. The red anterior vertebral line passes up the front of the vertebral body. The brown posterior vertebral line passes up the posterior aspect of the vertebral body. The spinolaminar line joins the basis of the spinous processes, and the posterior spinous line forms a curve along the tips of the spinous processes. These lines are crucial. Any step in these lines indicates potential fracture, dislocation, or ligamental injury. We'll go over some examples of this in the 3rd module. After you've assessed alignment, it's time to go on to bones. The vertebral bodies below C2 should be uniform in size and in shape. Follow these the whole way round, as even a small bony avulsion may be the only sign of an underlying unstable injury. As you move posteriorly, you should see the double line of the 2 facet joints nicely stacked on top of each other. You should then be able to trace an intact spinous process for each level. As you look at the top of the lateral view, there are several important review areas. There is a gap, the predental space, between the anterior arch of C1 and the odontoid peg. Normally this distance is less than 3 mm in an adult or 5 mm in children. Widening here may indicate either fracture or ligamental injury. If you look more closely at C2, you can see an incomplete ring-like structure. This is called Harris's ring, and any disruption to this can be the subtle signs of a C2 fracture. I always use this point to recheck my alignment of C1 and C2. Any fracture through the dens here can cause anterior or posterior movement. As the spinal canal is wide at this point, these unstable fractures can move significant distances before any damage to the cord is done. Sometimes patients with these peg fractures can walk into the department holding their head in their hands. They often tell you their head feels unstable. If this happens, then do take them seriously. I've certainly seen it once or twice before. The last part of the cartilage assessment is just to ensure that the disc heights are uniform at each level. Soft tissues can be very useful in identifying subtle injuries, as an abnormal swelling may be due to hematoma from a fracture. Normally in adults, they are less than 10 mm at C1, nasopharyngeal space, less than 8 mm from C2 to C4 in the retropharyngeal space, and less than 23 mm in adults from C5 to C7, the retrotracheal space. As these findings are quite variable, you're often looking for a change in soft tissue contour rather than an absolute diameter change. Now we've gone over a lot of information if you've never interpreted C-spine X-rays before. This is a good opportunity to go over what we've learned about each views. We're going to put up 3 x-rays. I'd like you to work through each of these x-rays using your AABCS algorithm and see if you can spot the fracture. Now pause the video until you're happy with your interpretation. Welcome back. Now this PEG view is adequate. We can see the dens and we can see the lateral bodies of C1 and C2. In fact, you can see so much, I wonder if the patient had a collar on at all. The lateral bodies seem to be in the normal alignment. There's a hint of an overhang on the right, but it's likely secondary to a little bit of rotation. When you go over the bones, however, you should see that the dens has a radiolucent line at the base. This is a type 2 fracture and unstable. If the patient presenting following acute neck injury, then this patient needs immobilisation and discussion with the spinal team. Now let's try working through an AP image. Pause the video now. So on reviewing this X-ray, there's enough of the neck shown to make this image adequate. There's no real adequate criteria for an AP view. When you draw your alignment lines through the spinous processes, you may have had some issues, as they just don't seem to fit. So this is probably how your lines looked. The top spinous processes are bifid, so you have to use a point in the middle for your line. They seem to cross around the C6, C7 level. And when you come to look at your cartilage and soft tissues, there seems to be a radiolucent gap on the patient's left at the C6-7 level, and there's no pneumothorax or obvious fracture to the lateral processes. This alignment change is consistent with a unilateral facet joint dislocation, with one facet just perched on top of the one below. This patient's going to need immobilisation, a CT scan, and a spinal opinion. So here is the last X-ray. It's one of the more difficult fractures to spot. So pause the video now and have a look using your AABCS. So working through it using our AABCS pattern, this lateral view is adequate. We can see all the way from C1 to T1. So when we come to alignment, the first 3 lines seem to be completely normal. That's the line up the anterior aspect of the vertebral bodies, the posterior aspect, and the spinolaminar line. The posterior spinous line does seem to be a little bit wonky. As we work our way through the bones, the vertebral bodies all seem normal, in size and in shape. And there seems to be no problem with the facet joints all stacking on top of each other. However, as you go over the spinous processes, you've worked your way all the way down to C7, you'll see something a little bit unusual. This is the fracture, and it's called a Clay-Shoveler's fracture. Looking over your review areas to continue your assessment, your Harris's ring, your predental space, they all seem normal, and your C1-2 alignment reveals no other pathology. The disc spaces look uniform, and the soft tissue doesn't have any problems. So, congratulations if you managed to spot that fracture. It's one that's easily missed, especially on a busy night shift with lots of patients waiting to be seen. Well done! This is the end of the module. We've gone over the need to use a systematic approach such as AABCS when interpreting C-spine X-rays, and to force yourself to go over those review areas. To be adequate, your PEG view must show the lateral masses of C1 and C2 and the whole of the dens, and your lateral view needs to include the top of T1. If for any reason your images aren't adequate, then you can't say there's no fracture, and you need to think about how you're going to image them further. You're going to remember to draw your 4 alignment lines on the lateral view, and your lateral alignment lines on the PEG view. And you're going to think about soft tissues on that lateral view. As with everything in the emergency department, if you've got concerns, just ask. There'll always be a consultant or a registrar on the shop floor who will be experienced in looking after patients with potential C-spine injuries. As I mentioned in the previous module, normal, adequate X-rays can still miss significant unstable injuries. So if there's any concerns with your patients, this would be a great reason to talk to them. If you've got any questions, then please find me on the shop floor or use the comments section. If you want to buy a book on the subject to read further, then then I'd recommend Accident Emergency Radiology, a Survival Guide by Raby et al. If you'd like some free material though, head over to the e-learning page. The next module in the series is going to go over some common fractures and will be a chance for you to put your new knowledge into practice. Thank you.